Very good evening to one and all, except Dr. Gokula sir. Very good morning, sir. And after this Diwali feast, let us celebrate this academic feast on geriatric pulmonary medicine, which has been designed by our beloved Dr. N.H. Krishna, who is he's actually playing the role of Krishna for all CCI family in the current days. So at the outset, I would like to thank you, Dr. N.H. Krishna sir, all officials of the CCI, including Dr. Ashish Dubey, who is National President, Dr. Anil Maske, who is National Secretary, then Dr. Vijay Kumar Channam Shetty, who is CCI Coordinator, and Dr. Atri Gangopadhyay for his unconditional support for this academic via CCI. So today's topic is old geriatric pulmonary medicine. As there is saying, old is gold. So geriatrics means age more than 65 years, and atric means medical management. So geriatric medicine is a branch which deals with the clinical, medical, preventive, and social aspect of the geriatric population, and which is very, very important. As I went through all of our standard textbooks of pulmonary medicine, nothing has mentioned the typical topic on geriatric pulmonary medicine. So I think today's webinar will be landmark for the postgraduate students, as well as to encourage our knowledge also for day to do practice in the geriatric medicine. So with these few words, I would like to introduce our today's panelists. First and foremost, I would like to introduce Dr. SK Chhabra sir. I think he doesn't require any introduction, as he is one of the pioneer in the field of pulmonary medicine, as well as far as India as well as abroad is concerned. So currently he is working at Primus Multi-Speciality Hospital as a head of the pulmonary critical and sleep medicine department at New Delhi. Our second panelist is Dr. Murthy Gokula sir, who is actually board certified in the geriatric and lifestyle medicine. He is currently working as a clinical assistant professor of family medicine at University of Toledo, Ohio, that is in USA. Our third panelist for today's discussion is Dr. Mahesh Mishra, who is a professor and head of pulmonary medicine department at Mahatma Gandhi Hospital, Jaipur. Our fourth panelist is Dr. K Aman, who is working as a geriatrician at Ranchi. He has his own setup, as well as he is attached to other hospitals also over there. And our last panelist for today's discussion is Dr. Mahesh Dev, who is working as a pulmonologist at ESIC Hospital, Ezhukone, that is in Kerala. So with this brief introduction for today's panelist, I would like to invite Murthy Gokula sir for his presentation on geriatric syndromes. Over to you, sir. Thank you.
Hello, everyone. Thank you very much for inviting me. And it's a wonderful panel and wonderful topic. And this is something that I'm very passionate about. And I want to thank CCI for inviting me to this conference and for introducing me to this wonderful panel and group. Especially, I want to thank Dr. N.H. Krishna and Dr. Narayan Pradeepa and my dear friend, Dr. Vijay Chinamsetti. I am a family physician, geriatric specialist, and recently I moved into lifestyle medicine. And I've been managing chronic diseases for the last 18 years, specifically focusing on geriatrics for almost 18 years. I started the fellowship at the University of Toledo in geriatrics and ran it for 9 years. And now I have a concierge medicine practice that predominantly focuses on geriatrics and adults. When you talk about geriatric syndromes, there are several syndromes. And I'll explain to you why you call them syndromes and what led them to call geriatric syndromes. Frailty, visual impairment, hearing impairment, dizziness, syncope, malnutrition, eating and feeding problems, urinary incontinence, gait impairment, falls, osteoporosis, dementia, and behavioral problems and dementia, delirium, sleep problems, and pressure ulcers and wound care. It's very difficult to give a small 15-minute session on all this, wherein in fellowship, we actually teach them each of this topic over the year. And before I go into the syndromes, I want people to think of geriatrics as I commonly say, how do you practice geriatrics? I tell them that I create simplicity from complexity to manage multimorbidity. So what's multimorbidity? It's nothing but when you manage more than 3 chronic diseases, because most of the older adults in US, we use 65 years of age as the cutoff point for geriatrics. You see that it's affecting more than 50%. And then each person, based on his physiologic reserve, has a distinctive cumulative effects and how the phenotype actually manifests in these individuals. So 2 individuals having the same chronic problems, they present with the geriatric syndromes differently. Because as you all know, that as you age, your physiologic reserve keeps diminishing. And the best way that I've seen recently after getting board certified in lifestyle medicine is if you practice the 6 pillars, the nutrition, the stress management, the sleep, addictions, social relationships, and exercise on a daily basis, then you can actually change the genotype with downregulation and then effectively change what manifests in these older adults. When you have multiple medical problems, you have an increase in death, disability, and then adverse treatment effects, institutionalization and utilization of healthcare resources, and decreased quality of life. The point is, when you're managing geriatrics, it's very important that you think about the physiologic changes that happen with aging in a holistic way, that each organ is affected. And one of the important things is the kidneys, the ability to clear. And here we talk about the lungs, which I'll be talking to you in the next few slides. So geriatrics is very important, and we're different than family medicine and internal medicine. After a year of training, what changes is not that we suddenly become very brilliant than family medicine physicians or internal medicine physicians, but our approach to these older adults, the approach to put a complex situation with chronic problems and focus on their function and quality of life. So what happens is, what you have to look at older adults is the illness severity, the functional status, the prognosis, and their personal priorities and the risk of adverse events. And then also, you can't apply clinical guidelines uniformly for every older adult. You got to look at their situation, their patient choices, patient preferences, family choices and family preferences, the cultural values. And based on that, you create a flexible approach to manage the multimorbidity. And the problems with clinical guidelines is that you focus on the management of one disease. And in geriatrics, we often call that when you're managing one problem, for example, in diabetes, it's important to manage the kidney protection. So they put them on an ACE inhibitor, but as you age, your GFR drops and ACE inhibitors retain potassium, and you can get hyperkalemia if you don't follow through. And then once you give K-oxalate, you can get hypokalemia. And if you have thiazide diuretics on top of it, you can push them into severe hypokalemia. So it's very important that you put a perspective to what you're doing, managing their drug-drug interactions, drug-disease interaction, and addressing the polypharmacy. I usually use medications as the 5th vital sign. And I always tell that if you focus on the medication list and their symptomatology, you'll be an excellent geriatrician. Consider all the problems that older adults present as one of the problems associated with medications as one of the differential diagnoses. And I don't really care much about the guidelines because they are either underrepresented in clinical trials or the observational studies, and most of the meta-analysis, systematic reviews, and the guidelines, they're not clearly done in these older adults to translate that. They're done in healthy adults, and then you extrapolate most of this. There are very few studies. And sometimes CPG-based care is cumulatively impractical, irrelevant, or even harmful for patients with multimorbidity. So what do you look at an older adult when you're approaching their evaluation and management? Usually we look at the 5 domains: the patient preferences, what's the evidence, what's the prognosis, the clinical feasibility, and optimizing therapies and care plans. I used to joke around, I said my MP4 model, wherein, for every problem in geriatrics, you have an acute situation and you have a chronic situation. You have patient preferences and patient value systems. The same way, families have their preferences and the value systems. But then you put into my jukebox, I call that MP4, wherein you look at that particular situation, the microbiology, the pathology, the physiology, the pharmacology, and then the psychosocial situation. And then the song that comes out of my jukebox is function and quality of life. So if you want to be a great geriatrician, focus on every time that you're trying to do or manage any of the geriatric syndromes. If I manage this syndrome, am I improving the function? Am I improving the quality of life? And if you're really not doing that, you kind of look at that. And for people who want learn geriatrics well, there is a website called pogoe.org, pogoe.org. And for prognosis, you can prognosticate a certain situation by going to eprognosis.org. And for polypharmacy, we use deprescribing.org. These are all websites that I can share later, and you can make your life easy. But I want you to understand that the geriatrics approach to evaluation and management is predominantly focusing on function and quality of life. Now, since this conference is all about lung, let's talk about what happens in the body. There's decreased elastin fibers, and that translates to decreased effort-dependent respiration, and there is increased collagen crosslinks, decreased elastic recoil of the lung, increased residual volume, decreased vital capacity, forced expiratory volume, and forced vital capacity. Thereby, the consequences of lung changes, as you know, there's a lot of COPD that happens despite them not smoking, and aging itself pushes people into the COPD pattern of lung, whereas there's decreased effort, dependent and independent respiration, quiet and forced breathing, decreased exercise tolerance, and pulmonary reserve. You can all see that older adults present with atelectasis, which is normal. And it's very important after they get admitted to the hospital that you do incentive spirometry and don't just jump because bilateral crackles are normal. And I usually tell my residents and fellows to kind of look at the sacral area if they're sitting for more than 2-3 days in that chair in the hospital or in the bed to see if there is dependent edema. So the way we manage geriatrics is we do a comprehensive geriatric assessment. And as I alluded earlier, that we focus on function and quality of life. We involve patients and families. And that's how we kind of address their medical, psychosocial, and functional capabilities and limitations. We create a treatment plan for long term. And so one of the things that we do is in the assessment, you focus on cognition, and I'll talk about that when we get into the syndromes, the functional status, the activities of daily living, and instrumental activities of daily living, the nutrition, medication review, comprehensive history and physical exam. And the geriatrics care team usually has a geriatrician, a nurse practitioner, social worker, a case manager, therapist, and other geriatric specialists. So I want you to understand what happens in geriatric syndromes. Usually there are shared risk factors for each of the problems. And if you look at that, incontinence, falls, pressure ulcers, delirium, and functional decline, they all lead to frailty. And as you all know, that due to aging, from 30 years of age, your muscle gets shortened. And if you don't use it, you lose it. And as age progresses, the muscle loss is pretty evident, and patients can't get up from their chair and they fall. So if they're incontinent and they can't go, that they kind of wet themselves, and that worsens frailty. So just for example, if an older adult stays in the bed for 24 hours, their function is declined by 3 days. This is just an arbitrary way that we tell families that how important it is for them to start doing physical therapy. And frailty leads to disability, dependence, going to an institutional for their living, and sometimes death. So normally in normal medicine, you see a linear progression. Like patients come, you look at their history, their risk factor, you kind of say early or advanced disease. And usually in oncology, they have progressed to a concentric model where at least they take 2-3 risk factors and that manifests as their clinical problem. But in geriatrics, it's very interactive and concentric. For risk factor, there are several risk factors, and then they synergistically cause a geriatric syndrome. And then you can't just individually apply a clinical guideline for each of this. You kind of look at the holistic approach. And then I call that buy one, get 10 free, wherein if you do one change, then it should affect the other 3 diseases and then help them to kind of, for example, when they fall, I check their lower extremity strength by doing a simple test in the office called 5-chair stand test. And if they're falling, I order physical therapy. If they're falling, then I do orthostatic hypotension. I'll check for immediate, if there is any new medication that has been added. I'll also call and talk about what's the vitamin D level. So I look at this in an interactive way, and then I kind of do targeted intervention. So let's talk about briefly, about these geriatric syndromes. And what I did for you all is, in the last slide, I gave you some questions. For example, in dementia, you can just quickly screen them in the clinic as, do you feel like you have a problem with memory? For delirium, you can say, have you noticed a sudden change in behavior or confusion with the family? Falls, have you fallen recently in the last 2 weeks? Do you fall frequently? Urinary incontinence, you can just ask one simple question. Are you able to make it to the bathroom without any accidents? Depression, are you depressed? Malnutrition, how is your appetite? Did you have any recent change in dentures? Insomnia, difficulty with sleep. But here's your resources. So if you go and open this link, this will take you to the actual link to the geriatric syndromes. And there are 2 resources that you can use and get all the details. But let me just go from the practical standpoint. For frailty, I explain to people that your muscle loss is pretty evident. You need to do some resistance training. And they usually complain of fatigue. And I check for testosterone levels. And we call that andropause. And it's very common, and people don't pay attention to it. So, and as you all know, that when you do resistance training, you improve longevity. And for visual impairment, I do a Snellen's real quick and go from there. Cataract is reversible, so it's very important that you pay attention to it. For hearing impairment, what I do in the clinic is a quick whispering test. I stay 5 feet away and whisper, and if they can hear, and that's pretty good. You don't need expensive equipment to screen for hearing impairment. And I check the ears to look for cerumen, which is very common. Dizziness is a very common complaint. You do a Dix-Hallpike test. You do an orthostatic blood pressure, and you listen to the carotids. And most of the time, C-spine stenosis, all these things cause dizziness. And recent medications. As I said, for all this, please have medications as the differential diagnosis. And for syncope, as you know, in elderly patients, as you age, your atherosclerosis gets worse, we have this vasovagal syncope or postprandial syncope, which is very common after eating, micturition syncope because of enlarged prostate. So we look at syncope differently than a neurologist because there are other causes that can cause syncope apart from just the neurological causes of syncope. Malnutrition, I look at their teeth. I'll make sure that how much they're eating and how they're improving. I predominantly now prescribe whole food, plant-based diet, and I avoid processed food, sugar, animal products, including eggs, dairy, refined flour, and gluten. That's a whole different discussion. But having done geriatrics for so long and managing chronic diseases, your problems are because of inflammation and insulin resistance. And if you fix these two, most of your health chronic problems get better. Eating and feeding problems, as you all know, that there is decreased gastrointestinal motility in elderly patients, and due to lack of dentures, they don't feed well, and it's very evident that weight loss becomes a problem. Urinary incontinence, there are several kinds, but there's urge incontinence and stress incontinence, and we focus on these things because it's quality of life. People don't want to leave their homes because they don't want to wear a diaper, and then they stay home and they get socially isolated. So it's very important that you check their bladder for post-void residual, you check their rectum for constipation. And it's amazing how many times by just fixing these two, I've resolved their urinary incontinence. And think of postmenopausal situation. And in females, if you just give estriol for the vaginal epithelium to build, and you can resolve simple things. Same with older adults with the prostate, check for their BPH and manage that appropriately. Gait impairment, I do a 5-chair stand test. I check for their quadriceps, and I immediately send them for physical therapy and or give them a home exercise program. Falls, always please check. It's a law in my clinic that I check orthostatic blood pressure with 1 minute difference between sitting and standing, or supine sitting and standing. And falls always, it's a very complex multifactorial causes, and check the vitamin D levels. It's very important. Osteoporosis, everybody gets a DEXA scan, check their vitamin D levels, look at for medications that can cause osteoporosis and stop them. And dementia, it's very important. I use what is called St. Louis University Mental Status Scale and Montreal Cognitive Assessment Scale. I don't use MMSE because it cannot pick up mild cognitive impairment. So that's why I use the SLUMS and the MOCA. And behavioral problems are very common, and people throw antipsychotics on these people. They don't help. Most of the times you need to figure out what are the preventable causes. And most of the times thyroid, B12, new drugs, these are all things that normal pressure hydrocephalus, and then you can manage them. And there is a wonderful resource for behavioral problems to manage in dementia. You just Google UCLA dementia videos, and you can see them and address them non-pharmacologically. Delirium, I use what is called confusion assessment method. And it's very common, especially in the hospitalized patients. You're all pulmonology critical care people. And it's very important you diagnose it. In the ICU, we use what is called ICU CAM. And it's a wonderful tool. There's a book. Even if you're intubated, you can use that and check for the delirium and address it appropriately. Sleep problems are very common in elderly. They cause sleep-wake cycle dysfunction. And it's very important that you manage them appropriately. And normally I use a 10,000 lux light, usually to address sleep problems and sleep diary, and sleep apnea is very common. And you can check for that by doing a sleep study. Pressure ulcers and wound care is very important. Pressure ulcers, all it takes is 20 pascals of pressure for about 15 minutes to create a stage 1 pressure ulcer in these patients. So it's very important that you pay attention to the skin. And because of the loss of water in the skin, we get dry skin. So it's very important to give them moisturizing creams. So this is a quick overview of geriatric syndromes. And as I said, you can use these questions, and these are the resources that you can download. You get a PDF, and I'll be happy to answer questions Thank you very much for your time.
Of these geriatric syndromes. And first of all, thank you from all CCI family for accepting our invitation and to be present here for our webinar, wonderful webinar. So, with your presentation, I came to know few things. Those are very, very important. That medication, one of the vital signs you have mentioned, that is very, very important thing. Each and every time you should go to the patient's medication list. Such some patients may be suffering from this some of the other medication side effects also, and they will be consulting the physicians. So, with this your excellent presentation, I would like to invite our today's second presenter, Dr. Mahesh Mishra sir, on the lung physiological changes with the aging. Over to you, sir. Thank you.
Thank you, CCI, for giving opportunity to be here to speak on physiological changes in lung with geriatric age. Thank you to Dr. Mote for a nice introduction. I am going to why this topic is important, because geriatric population is at increasingly faster rate each year due to the better access to medical field and its development. With such a large, rapidly growing aging population, it is critical to understand how body changes with the age and how this impacts entire respiratory system. Respiratory system undergoes various structural, physiological, and immunological changes with the age. These changes may predispose to these elderly individuals to increase risk for the respiratory diseases. Moreover, these changes in part be responsible for the variable response to currently available drugs to treat pulmonary diseases in elderly people. So, understanding the aging process in the lung is necessary in order to provide optimal care to our aging population. Basically, there are 4 changes that happens with aging in relation to the respiratory system. One is structural and functional changes with age. Another is inflammatory changes. Another is changes in pulmonary immunity. Another is natural disease development with the aging. I will take one by one all of 4. We know the respiratory system comprises primarily of thoracic cage, lungs, and diaphragm. Any structural change, any of above 3 structures, is going to affect lung function. So narrowing of intervertebral space with age causes kyphosis that result in the decrease of space between the ribs that subsequently create the smaller chest cavity. After the age of 40 years, kyphosis increases more rapidly, hence causing more smaller chest cavity. Then what happens to the smaller chest cavity? It reduces the ability of thoracic cage to expand during inspiration and placing the diaphragm at a mechanical disadvantage to generate effective contraction, which is the most important part of respiration. Rib space narrowing, which decreases the length of intercostal muscles. The angle of the muscle fiber in relation to rib may also affect the efficiency and decrease the movement of lower rib during inspiration. As a result, significant decline observed in FEV1 and vital capacity in the geriatric population. This diagram showing relation of lung function with the age. As you can see, lung function maximally achieved at the age of around 20 years. After that, FEV1 start to decline, or after the age of 40, FEV1 decline more rapidly. So we all know what is the consequence of decline FEV1 in the normal people. Another is decreased mucociliary clearance. Why it happens? It is due to reduced cough strength and alteration of body ability to clear large and smaller particle areas with aging. It may be due to beat frequency of cilia. This diagram showing physiological change in aging which place an elderly patient at risk for the poor airway clearance, increased mucociliary dysfunction, poor airway clearance, decreased muscle performance, and decreased cough strength. This is the diagram showing age immune system, age immune inflammatory changes. Left hand side is showing young adult, right hand side elderly people. You can see basal activation of innate immune system in the absence of immunological threat. We can see that elevated level of these cytokines in elderly people may be caused of reduced elasticity and for the blunted immune response known as immunosenescence following injury. Now we come to the pulmonary immunity. Lung has immunological defense that are both complex and resourceful, utilizing both an innate and adaptive immune response to inhale antigen. Innate immunity is a critical first-line defense for the lungs. Adaptive immunity is antigen specific and is required to ward off encapsulated bacteria, viruses, intracellular pathogens. This form of immunity relies on immunological memory, lymphocyte production of antibody to non-cell threat. Some important change in the innate immunity response may occur with the age. An age-related aberrant initiation of immune response may be responsible for the slow recognition and eradication. The antibody secreting capacity of B cell is reduced with the age, perhaps leading to a less robust immunological response when needed. Thymus is primarily responsible for the producing naive T cell and replaced by fatty tissue by the age of 60 years, resulting defective immune response. Now we come to the natural respiratory disease development. The prevalence of COPD is 2 to 3 times higher in people over the age of 60 years. Smoking is the greatest factor for the developing COPD in a genetically susceptible individual. Due to the age-associated changes in the structure and function of lung, increasing the pathogenic susceptibility to COPD. These changes describe elderly lifelong non-smoker characterized by age space dilatation, resulting from a loss of supporting tissue without alveolar destruction. Similar changes seen with the COPD patient. Now, in the summary, the size of thoracic cavity decreases, limiting lung volume, altering the muscle that aid in respiration. Muscle function on a cellular level is less efficient and has the decreased reserve. Cough strength is reduced in the elderly population due to various anatomic changes and muscular changes. Clearance of particle for the lung through the mucociliary elevator is negatively impacted and associated with ciliary dysfunction. There are many complex changes in the immunity with the aging that increase susceptibility to the infection, including late robust immune response, effective innate immune response, and adaptive immune system. Thank you very much for the patience.
With the aging in the lungs. Thank you very much, sir. So After this two presentation, we are moving towards today's most important part of our today's webinar, that is question and answer discussion. So, with due permission of our panelists, I would like to start my question and answer session. So, first question goes to SK Chhabra sir. Sir, so what are the common causes of dyspnea in the geriatric population?
We have just heard two very important and enlightening talks on geriatric syndromes and physiological changes. So, and that clearly tells us that as we age, there are certain symptoms which are expected as part of aging. So very often, people in this age group, they are weaker, so the capacity to work is reduced and they get breathless more easily. Now, dyspnea, as we know, is the commonest symptom of respiratory disease. So dyspnea in the elderly has to be differentiated from a physiological process, because a person who is 65 or 70 cannot have that kind of exercise capacity as a younger person, versus whether it's pathological. Now, there are many diseases, pulmonary diseases, which are more prevalent in the elderly. Classically, COPD, the prevalence increases with aging. And then among the interstitial lung diseases, idiopathic pulmonary fibrosis, that is the prototype lung disease, interstitial disease, which occurs in the elderly. So these are two most important causes of dyspnea on exertion. Plus, lung cancers are also more common in the elderly. So these are some of the common pulmonary causes. Then, because these patients also have comorbidities, cardiac causes contribute. And it is very common that patients have a pulmonary disease, but they also have a cardiac disease. They could have a systolic heart failure, they could have a diastolic heart failure. So management is incomplete without a cardiac assessment. Plus other factors like deconditioning, because these patients generally lead a more sedentary life. So as we have heard, the muscle mass decreases with aging, and if one doesn't use the muscles, one loses the muscle. So that leads to deconditioning. And when suddenly a person has to do a task, he gets more breathless. Anemia, malnutrition, these are other important causes. So the causes of dyspnea in the elderly population are much different from a younger population, and a comprehensive and a holistic view is required, focusing not only on lungs, but the overall physiological changes and the other systems.
Thank you, sir. Thank you for your excellent elaboration in 2 minutes for regarding this most common causes of dyspnea in the elderly population. My next question goes to Dr. Mahesh Dev. What are the predisposing factors that geriatric population is more prone to develop this infective etiologies like tuberculosis? What are the predisposing factors in the geriatric population?
Yes, sir. Okay. So first of all, I want to thank Dr. N.H. Krishna sir and Narayana Pradip sir as well as Atlas sir for this opportunity. Also thanking Dr. Murthy sir as well as Dr. Mahesh Mishra sir for this excellent presentation. So let's coming back to the question. As sir already told, actually, whenever the age advances, there is decline in the immunity. So clearly mentioned, actually, there is decline in the naive T cells, which leads to decline in the T cell mediated immunity. Hence, there is the reactivation of latent tubercular foci occurs. That is a major pathology here, and also other associated factors like uncontrolled diabetes and malignancy, other immunosuppressive agents that the patients may taking, and underlying other chronic conditions and even chronic lung conditions, malnutrition, and excess alcohol intake, and chronic smoking status, and the use of other immunosuppressive agents. These all factors may contribute the decline in the immune system, specifically cell-mediated immunity, that may impart to the increased predisposing to this infectious etiologies, especially tuberculosis.
Okay. One of the factor, thank you, Dr. Mahesh. One of the factor that is immunosenescence, which is actually a decrease in the immunity as adaptive as well as innate immunity in the geriatric population, that may also contributing for the development of such kind of chronic condition. Thank you very much, Dr. Mahesh Dev. My next question is to Dr. K Aman. Please brief about the geriatric medicine. Just in few words, within 2 minutes, you have to brief regarding the geriatrics. Dr. K Aman, please.
Yes. Hi, first of all, very good evening to everybody. Thank you for the opportunity for letting me speak in this platform. So geriatrics. Geriatric medicine is a very young branch of medicine which deals with the elderly patients. According to the protocol, a patient above 60 years of age is taken as elderly. We take geriatrics in 3 segments of the population. The first segment is 60 to 65, which is young old. The second is the second is 75 to 85, which is an old, and the third is 85 above, which is very old. So the first scenario is from 60 to 75. The patients in this criteria, in this strata, are more or less similar to the adults. So though they don't have much biological and symptomatic changes in them. The second strata comes, which is 75 to 85. They have some senile degeneration, some biological changes, some mental restrictions. So there are some needs of special efforts to these kind of population. The third is 85 and above. These patients are more and much more prone to senile degenerations, and they need a caretaker to take a good care of them so that they can perform their day-to-day life. So these are the 3 status in which we deal with the geriatric patients. Thank you.
Thank you, Dr. Aman, for your deep elaboration. Just would like to add in that one that you have said regarding geriatric that 65 to 75 years of age is actually middle old. 75 to 85 years of age is middle old. 65
old and very old.
Sorry, 65 to 75 is young old. 75 to 85 is the middle old. More than 85 years of age is actually old,
very old,
and more than 100 years of age is elite old. That is called. So thank you for enlightening us on this terminology. So my next question is to Dr. Murthy Gokula, sir. Sir, just brief regarding this normal physiological changes in the lung with the aging. Important physiological changes in the lungs with the aging. Murthy Gokula, sir, please.
Yeah, thank you for that question. I think I'll talk about the clinical aspects that actually relevant matters for clinical outcomes. So as you all know, that sarcopenia, which is loss of muscle, can cause the same overall musculature, and then the decreased elastic recoil, and the costal cartilages that get calcified. And that all leads to there's bronchial mucosal glands increase. They increase secretions, and then because of the increased cross-linking, decreased elastic recoil, all this cause negative intrathoracic pressure that do matter for lung issues. And they are more prone for the diseases Dr. Chhabra elucidated. But what I care about in older adults is what they should be doing actually every day is practice pranayama every single day. And that has shown, we call that in US, a nice fancy terminology called pulmonary rehabilitation, and they make money. Wherein yoga is so underrepresented in India, despite we are the ones who created that for the world.
Yes.
So I would want each physician who is listening to me start doing pranayama on a daily basis with all your patients, and you'll be amazed to see how much improvement you can do with the actual physiological changes with aging. And I have proved it in the nursing home. We did during COVID a candle test and try to do them. My numbers are small, but actually it helped during that time. And so the physiologic changes, while you all have heard, what I would like to do is the practical aspects of how you can actually make a difference in these people. And as you all know, that the negative changes lead to COPD, emphysema, bronchitis, sleep apnea, lung cancer. And what I think are critical is that the decreased intrathoracic negative pressure and airway collapse that happens. Another thing that I want to mention that has not been mentioned is there is increased residual volume, 20 ml per year. Vital capacity is decreased, and the FEV and the FEVs FVC decreases by 30% by the age of 80 years. So putting all that, I'm a very simple, practical guy. I told you, right? I create simplicity from complexity to manage multimorbidity. So my suggestion for everybody who is listening to me today is, please, more than the changes that happen in physiology, please tell your patients to start doing pranayama every day. Thank you.
Thank you, sir. Thank you for your kind words regarding this normal physiological changes in the geriatric population. So actually, there is one thing I would like to tell all of you people. The lung compliance with the age in the geriatric population, it will increase, but the chest wall compliance will decrease. So overall, there will be decrease in the pulmonary system compliance as well as the age advances in the geriatric population. That will lead to a lot of pathologies, as we have discussed just. So moving towards Mahesh Mishra sir. Sir, can you brief regarding role of adult vaccination in the geriatric population? Role of adult vaccination. Mahesh Mishra sir, please. Sir, you have to unmute yourself, sir. Mahesh Mishra sir.
Mahesh sir, you're not audible. Kindly unmute it, please.
Am I audible now?
Yeah. Yes, sir.
Yes.
Now you are ready.
Yes, sir, you are.
Go ahead, sir. Please.
Vaccination in children is a well recognized entity across the globe. But vaccination in geriatric population is still a recognized entity even in the developed countries. Various guidelines recommend flu and pneumococcal vaccine in all geriatric population. There are two kinds of pneumococcal vaccine. One is conjugate vaccine, another is polysaccharide vaccine. Conjugate vaccine is more potent, more antigenic, more lasting memory. While polysaccharide vaccine is less lasting memory but more strength. Recently, CDC recommended PCV 20, single vaccine. Previously, they recommended PC 13 followed by PSV 23 vaccine. Another vaccine has which come to recent highlight is COVID vaccine. COVID vaccine also recommended. Apart from COVID, pneumococcal and flu, there is a diphtheria, pertussis, tetanus vaccine should be given to geriatric population. And it is shown very studies that pneumococcal vaccine and flu vaccine quite effective in preventing serious kind of illness. So we should make it practice that flu and pneumococcal, these two vaccines must be offered to our geriatric population.
Yes. Thank you, sir. And as far as vaccine is concerned, sir has rightly mentioned these two vaccines are mandatory and must be offered to each and every individual who is in the geriatric population age. And there is one more problem with this vaccination. So as age advances in the geriatric population, immunity also will go down. So immunity to vaccination, whatever we are doing, as compared to younger generation or younger population, so compared to the geriatric population.
Dr. Toke, if you don't mind me adding, the 5 vaccines are, we give Tdap every 10 years.
Yes, sir.
We give shingles after 50 years.
Yes.
We do pneumovax, which you guys know, and then flu vaccine, and now we just added COVID to the regimen.
Yes. Yes. Thank you, sir. Thank you for enlightening us on the next. So coming back towards our question and answer session, I would like to ask next question to the SK Chhabra sir. Chhabra sir, what are the difficulties and challenges in diagnostic as well as investigation in the geriatric population?
Well, broadly, the tools of investigation remain the same in pulmonary medicine across all ages, but how we use them, that differs in the elderly population. For one, the risks with certain invasive investigations, these are more common, and one is not easily going to get a consent for an invasive investigation in the elderly. That is a genuine problem that one faces. People who are 70 or 80, they are more likely to refuse biopsies than a younger patient. So very often one has to do without a biopsy and go for clinical workup. Then these patients require a wider range of investigation. For example, a patient with dyspnea comes to me, then I will also look at his cardiac function, not only his respiratory function, but also at his cardiac function. So that will, because as I told earlier, the causes of dyspnea are wider in the elderly population. So the costs of investigation, these go up. In doing lung function testing, the issue of cooperation is there. And unless these patients are properly trained, because they may be cognitive impairment or physically they may not be able to do the test. So that element is there, that we do not get acceptability criteria fulfilled in these patients. Then because the lung function changes with age, reduces with age, one needs to have appropriate reference equations to make sense out of the data. That is very important.
Yes.
That in our population, especially I have published my work on reference equations, and in India, the lung function declines faster than in Caucasian population. So unless we use our own data, we are likely to overdiagnose. For example, if we go by the FEV by FVC ratio for diagnosing COPD, in the elderly population, we may overdiagnose COPD. So it has to be clinically correlated. So while the tools remain same, but there are practical issues in applying these tools, and one must be aware of the practical difficulties in applying these diagnostic tools in the elderly.
Thank you, sir. Thank you very much. My next question is to Dr. Mahesh Dev. What are the things to be noted while performing or interpreting PFT in the elderly population?
Yes, sir. Very relevant question. Thank you for that question. Already, dear Chhabra sir has clearly enlightened us regarding the major issues regarding the PFTs and what are the things we have to look for. But as we all know, actually, while as interpreting PFT, we are comparing the measured value with the predictive values. So, as Chhabra sir clearly depicted, the elderly are not well represented in most of the reference value reports. So, the number of subjects usually is so small when considering the age group of more than 80 or 85 years. So, the actual scenario is actually the preference value or data, the mean data volume is taken from the extrapolation of the younger reference points with the regressive equations. So we have to taken care of utmost care regarding the assessment of the PFT values. Otherwise, we may go erroneous values and we may overdiagnose most of the optic diseases. That's the one thing. So as per the ERS and ATS criteria, they are even the fixed ratio. If you want by FEC fixed ratio, they are demolishing and coming towards the percentile values and fifth percentile values. And depending upon that, actually, we may able to identify the objective criteria. One more thing is actually I want to add is predominantly whenever as the age advances in elderly population, there may be decline in the height. And whenever we are assessing the predictive values, this may also hampering by declining the height. That at that scenario we can take that arm span length and we can overtake that issue also. So altogether clinically we have to correlate with the PFT values and don't overdiagnose those kind of things. We have to give utmost importance to the clinical status also. Thank you.
Yeah, thank you, Dr. Mahesh. Thank you. My next question is to Dr. K Aman. What are the infections of the respiratory system most commonly seen in the geriatric populations? What are the most common infection of the respiratory system in the geriatric population?
For the question,
Dr. Aman,
sir.
please.
Yes, sir. Thank you for the question. So the most common diseases in the elderly. So there are two stratas which we divide basically, which are infective and non-infective. In infective, there are bacterial infections, viral infections, and fungal infections. In bacterial infections, there might be Streptococcus pneumoniae, which is most common bacterial infections, tuberculosis, pneumococcal infections. In viral, it might be COVID-19 and some common cough and cold. In fungal infections, aspergillosis is one of the most common causes, but it is very rare. It is not that common. Acute respiratory infections, lung abscesses might be there, but it might be of tubercular or fungal. So it might be an infective and non-infective as well. In non-infective, there are some pathological and allergies which can be collaborated. Thank you.
Just one question from my side to you. What about the gram positive or gram negative, which will be predominant infection in the geriatric population?
Gram negative, sir. Gram negative, gram negative is more predominant.
Gram negative as well as MDR or XDR bugs will be predominant in this geriatric population. Okay. Thank you very much, Dr. Aman.
Thank you.
My next question is to Murthy Gokula, sir. Sir, can you brief regarding this geriatric assessment? What assessment we have to do when the patient comes to us as a outpatient basis? Please.
Yeah, thank you. Geriatric assessment, if I have to focus in 2 minutes, first, after you take the history, you focus on the depression, which is very common, and screen with PHQ-9, dementia, and which you can use slums or MOCA, medication review to make sure that you assess it very thoroughly, and do orthostatic hypotension. We screen for vision, we screen for hearing, as I said, urinary incontinence. And one thing that most people, I'm sure culturally in India, they neglect, but here we ask on a routine basis, is sexual health. And I used to make it a point that all my fellows ask that. And the reason why it's very important is its quality of life. And one simple question can give you a lot of answers. If they're enjoying their sexual life, their endothelium is good, they don't have arthritis, they don't have depression, they don't have any pain issues. I'm just trying to extrapolate, how in a short time, our visits here are 30 minutes, geriatric assessment, we take 60 minutes, and we screen for all these conditions, like I say from the head to toe, from the head, we screen for dementia, depression, delirium. Delirium, we use confusion assessment method. And we check for hearing, we check for eyes, we check the oral cavity, look at their dentures, what's happening with their oral health. It's very common, and it's related to lungs because they don't have good oral health. You're more at risk for aspiration pneumonia and further problems. And they're dry. I often say that you need to make sure that you have to drink half your body weight to kind of give adequate hydration for the older adult. And then I go down and look at their lungs, heart. Very commonly missed is neck. They don't check for thyroid and carotid bruits. And I also look at the supraclavicular areas for bruits, and I've diagnosed several atherosclerotic related issues and decreased blood flow. And then I check for gynecomastia and look at if there is problems related to their hormones. And abdomen, obviously, we assess regularly. And coming down, I check for hernias and testicular health, very important. And I also look for hernias, which are also common in the elderly. And then the lower extremity, we do what is called get up and go test, or we can do a 5-chair stand test. All they have to do is sit with their arms folded, get up. And if they take more than 30 seconds, they have increased risk for falls. And then going down, we look at their feet, which is commonly missed. And along with the feet, we look at the spine. There's a lot of bone changes, muscle changes that predispose them to scoliosis, kyphosis, and that creates instability with their loss of change in their center for gravity and predisposes them to falls. And as you go down in the feet, I always check to see what calluses they have, and if they have flat feet, and create an arch support for them, simple things that will help. Most of the older adults will have crowding of the toes, and they don't put their feet down because of hallux rigidus or hallux valgus, varus deformities, and we address those issues. So this is a quick geriatric assessment that we do if I have to say, but I'm going to share in the chat an article from American Academy of Family Physicians that describes geriatric assessment in detail. Thank you.
Thank you very much, sir, for enlightening us on the geriatric assessment within a couple of minutes. Thank you very much. So my next question is to Dr. Mahesh Mishra, sir. Is there any role of non-pharmacological treatment in treating geriatric syndromes? Brief role of non-pharmacological treatment in treating geriatric syndrome. Mahesh Mishra, sir, please.
There is definite role of non-pharmacological measurement in geriatrics. As said by Dr. Murthy Gokula very beautifully that geriatric patients had multiple problems. One is problem in nutrition. Another problem is physical inactivity. Another problem is sensory deficit for the eye, for the ear. So these are the problems need to be taken. Geriatric patient we have seen the geriatric patient having problem of vitamin deficit, problem of malnourishment. So there is a need of protein-rich diet, vitamin-rich diet, mineral-rich diet to help to record this. And another thing, Dr. Murthy Gokula beautifully said that use pranayam. This means you should advise the patient with some sort of physical activity. So another is the behavioral therapy. Behavioral therapy is very important in the urinary incontinence. Pelvic muscle exercise, bladder muscle exercise. Another is health education. Health education to patient attendant also. Patient family is very important in the geriatric population. So we should explain the patient condition to his family also. Another is correction of sensory deficit like specs for the eyes, some audio aid, some danger for the eating purpose. So these are the non-pharmacological measures need to be taken in the geriatric population. Nutrition and physical activity is most important of these non-pharmacological measurements.
Thank you, sir. Thank you, sir. I think yoga is also very, very important as a non-pharmacological treatment for this geriatric syndromes, yoga and meditation. So again, I will come to Sir SK Chhabra, sir. Most important question actually: how do clinical presentation in pneumonia differs in elderly population, and how does management differs in compared to the younger generation or younger population?
Pneumonia is a very, very important problem in the elderly. In fact, it's a leading killer in this population. The classical symptoms of pneumonia in the younger population, fever, cough, chest pain, these may not be there in the elderly population. We have seen patients coming only with cognitive impairment, confusion, and when these are evaluated, it turns out they have got pneumonia, or a patient may only have weakness. Some patients come to the emergency in shock, no fever, no cough, and they are investigated and turns out they have got a pneumonia, or they may be brought unconscious. Hyponatremia is another common presentation, and when these patients are investigated, they are found to have pneumonia. So presentation is much different and atypical in the elderly. No classical fever very often, and then the lab investigations. A younger person will have a leukocytosis. In the elderly population, we may not see any leukocytosis. In fact, there may be leukopenia. Then these patients, because of their physiological changes, which we have discussed, they are at a disadvantage as far as their buffering capacity and capacity to handle the load is concerned. So the risk of respiratory failure greatly increases in the elderly population. We have got a pneumonia severity index. Now that places a very high premium on the age as a scoring criteria. So all patients who are 65 plus, if they have a pneumonia, they must be admitted. There's very little scope for outpatient management because these patients have got a very high mortality. So the risk of respiratory failure is high. So therefore one needs to be very aggressive, and a low threshold is required for ventilatory support more adverse effects, more drug interactions. So managing pneumonia is a real challenge, and that is why it is the leading cause of mortality in this population.
Thank you, sir. Thank you very much. And with your due permission, I would like to add one more thing on this one. In geriatric population, patient can present with pneumonia. Patient can present with hypotension without any tachycardia, and that may be contributed to the decreased baroreceptor sensitivity in the geriatric population, and as well as some of those patients might be getting this beta blockers for some heart diseases. So they may present in the hypotension without any tachycardia or other signs and symptoms of hypotension.
The shock is a very common presentation.
Yes. Thank you very much, sir. Thank you. My next question is to Dr. Mahesh Dev. What are the pre-op evaluation and anesthetic consideration in the geriatric population prior to the surgery?
Yeah.
Dr. Mahesh Dev,
excellent question, sir. Yes, sir. Excellent question, sir. First of all, I'll go towards the anesthetic consideration. So first of all, we already discussed actually grossly while considering the elderly geriatric age group. As the age advances, there is a decline in the elastic recoil, and there is chest wall decline in the chest wall compliance as well as the respiratory muscle strength. All these may lead towards the respiratory muscle fatigue, because whenever giving anesthetic agents, especially neuromuscular blockades and other sedatives like benzodiazepines, this will impart towards more towards respiratory fatigue, and one should taken care of that also. One should foresee that thing also. That is the one major implication. The other thing is actually, while considering in the parenchymal scenario, elderly more moving towards that emphysema kind of thing, that is general emphysema. So this will impart towards decline in the dead space, both physiological as well as anatomical, and there is a decline in the diffusion capacity. Apart from that, actually, there as already our speakers told, actually, there is increase in residual volume and compromise of vital capacity. All these things towards the CO2 retention. But the actual scenario is that actually there is diminished central response towards hypercarbia as well as hypoxia. And this will impart the things more worse, because there is at least more than 50% reduction in the respiratory drive due to this blinding of this central respiratory drive and central respiratory response towards hypercarbia as well as hypoxemia. So while we are imparting towards these anesthetic agents, including specifically towards neuromuscular blockades as well as these sedatives, then these blinding more worsens, and there is more chances of CO2 retention. There is more towards confusion, and that this can move towards life-threatening arrhythmias and even re-intubation. So that should be taken care of. That's one thing. Then another most important part is high risk of aspiration. That has already our beloved speakers clearly mentioned regarding the same. But I am imparting my thing actually, like there is reduced pharyngeal muscle tone, as well as there is decline in the cough reflex as well as upper esophageal upper pharyngeal reflexes. This imparts more towards reduction in the drainage of secretions. Also, while considering this oral cavity, there is more colonization of the gram-negative bacteria and pathogens. This will impart more towards this aspiration status, and one should more taken care of regarding this aspiration pneumonitis also. So, for taking care of that, actually, we should give pre-anesthetic medication, especially prokinetic agents and anti-secretory sodium citrate, as well as this glycopyrrolate. Etc. We can impart to this to overcome this situation here. And apart from that, I want to add one more thing is actually, like it should be applicable for both pre-op as well as peri-op as well as post-op criteria. Immediately we want to start actually incentive spirometry as well as deep breathing exercises and early ambulation and early mobilization for reducing these kind of complications also.
Yeah, thank you, Dr. Mahesh. Thank you.
Thank you, sir.
Excellent. Regarding incentive spirometry, very important role in post-op as well as pre-op also. We can start in prior with to avoid the post-op complications. Yeah. Thank you. My next question is to Dr. K Aman. Respiratory diseases, just brief regarding respiratory diseases which are most commonly seen in the geriatric population.
Thank you for the question, sir. The most common diseases which can be seen in the geriatric population is pneumonia, obviously, then asthma. Asthma is one of the most leading uh, disease in a geriatric population. Asthma is basically the inflammation of the interstitium and some deposition which causes distress in breathing and wheeze. Then COPD is one of the diseases. Bronchitis is one of the diseases. Emphysema is one of the diseases. Lung cancer is not that common, but yes, it is considered. Cystic fibrosis is one of the diseases. Pulmonary edema. Pulmonary edema can be there. There might be some interstitial lung diseases, and along with that, there are some uh, extrapleural or other organ involvement diseases. Like if a person is having some kidney related symptoms, then there might be a pleural effusion there, which causes difficulty in breathing. If call pulmonale is there, then that causes some deposition of fluid around the lungs, causes difficulty in breathing. Pleural effusions might be there, and lung abscesses and edemas might be there. Thank you.
Thank you very much. Thank you. And next question goes to our respected Gokula sir. What is this polypharmacy? Its definition and management.
Thank you. Polypharmacy, the definition is very heterogeneous. There is no fixed criteria, different studies, they have done systematic reviews. But in general, for accepted definition is 5 or more drugs. And while they're in an outpatient setting, and if they get the hospital and they get discharged with 10 or more drugs. I'm trying to simplify this for you. So polypharmacy definition is 5 or more. And if you look at all data, anytime you have 5 or more drugs, you will start, whether you like it or not, drug-drug interactions and drug-disease interactions. So that gives a nice segue into the signs and symptoms that normally you see with polypharmacy: dry mouth, tachycardia, confusion, diarrhea, constipation, peripheral edema, extrapyramidal side effects, syncope, orthostatic hypotension, hypoglycemia, congestive heart failure, pulmonary edema, flatulence, bloating, somnolence, and lethargy. I understand polypharmacy is complex, but I'll break it down very simple. There are certain patient factors because of old age, lack of proper education, health literacy. What I'm saying is I spoke with IAS officers and they're health illiterate. Female, low education level, rural living, multiple chronic problems, use of multiple medications, having multiple pharmacies dispense medication. And there are some systems issues. Many different prescribers, especially in India, where they see specialists, they don't have a primary care. There's poor record keeping sometimes from the patient side, from the system side, and failure to review the patient's medication at every interval and post-hospitalization. And as you know, the risk factors are people who have more than 85, low body mass index, and people who have 6 or more, and then the creatinine clearance less than 50 ml, prior adverse drug reaction. So how do you assess that? You know, it's very simple. I can give you some tools called modified Beers criteria. There is start and stop criteria, which is an European criteria that we use. Pretty much it's laid out for you. You can Google it and get it now because the data has been there for the last 15 years. And now they modified the start and stop criteria to create what is called PRISM criteria, which also educates physicians on when to actually do the labs on a regular basis. And in long-term care, we have what is called ARMOR criteria and medication appropriation index. So, and then, you know, when we see polypharmacy also, we kind of check as to what are the principles of prescribing. So every time you prescribe a drug for an older adult, you just question yourself, is this medication necessary? Do the benefits outweigh the risks? What are the desired therapeutic effects? And how do you measure them? What are the potential drug-drug interactions? And try to start one new medication at a time. And I hate to say this because of COVID and what I do in India with rural health. I've been exposed to medical system in India, and I see a lot of medications for each visit. And I've kind of looked at drug-drug interaction side effects and managed. And please, if there's one thing that you take home, start low, go slow, or we call that go low, go slow, and then you can always increase the dose. identify and explain the indications and the side effects that are common. For example, amlodipine, peripheral edema, very common. Identify and stop the duplication of medication. So the way I do it is I put the medication, the chronic problems on one side, medications on the other side. I match them. If there is no reason why they're there, I stop them. And I saw one question that giving Geri 4 to people in the chat box, if you're plant-based, whole food, whole grain, you need to give B12. Otherwise, I would put my little lifestyle hat here and say, please ask. When I did my boards in lifestyle medicine, this is all my grandma who taught me. And India has the wealth and the knowledge and the culture. And what we need to do is to go back to the roots, plant-based, whole food, whole grain nutrition, try to avoid the oils. And then you'll be amazed to see most of the deficiencies. And there's data that if you do this, sarcopenia is resolved. And sarcopenia translates to physiological outcomes in pulmonology with your chest, as I said. But I'll talk about lifestyle in my next question. Hopefully, we have time for that. But these are some of the ways you can actually manage polypharmacy by using the criteria and seeing the appropriateness of each medication, and making medications as your differential diagnosis for all the symptoms they come through will make you an excellent geriatrician.
Thank you very much, sir. Thank you very much. As far as India is concerned, each and every patient here will be getting 1 or 2 prescriptions or 1 or 2 drugs, or means that those multivitamin combination that might be syrup or that might be tablets. So again, it will add to and increase the polypharmacy chances here.
And actually, there is data that if you give indiscriminately multivitamins, you actually increase mortality for no reason.
Yes, yes, definitely. So actually, unless and until it is indicated, it should not be prescribed as far as these multivitamins are concerned. So coming towards Mahesh Mishra sir. Mishra sir, question to you. Management of elderly in the ICU. Any special consideration we have to take? We have to brief on this one.
Yes, elderly patient in ICU settings definitely require more care because they are associated with the less favorable outcome. Why there are many structural, functional, immunological changes with the geriatric ages that lead to the less favorable outcome, even the absence of comorbid disease, age-independent factor. So ICU patient, elderly ICU patient, little bit more vigilant. It needs multi-specialty approach, multi-modality approach. Neurologist, chest physician, physiotherapist, and intensivist. And also because there is a lot of cognitive impairment in the geriatric patient, so we need to be more vigilant for the expression. We need to be more vigilant for the expression. We need to be more vigilant for the oral hygiene. And another thing, various drugs. We need to be ensure which drug to be given, which drug to not to be given. Another more thing, what is the underlying disease? But we are getting benefit from the ICU care for that disease is reversible, not reversible. So these things should be taken in consideration. Risk versus benefit ratio always to basis, because there is the involvement of huge cost always in the treatment. What are the benefits we are going to get getting from giving intensive care to the patient? These things to be taken in the consideration the way we are treating patients in the intensive care units.
Thank you, sir. Thank you very much. Thank you. So my next question, again, very important question to our Lord Chhabra sir. Chhabra sir, what are the challenges in treating obstructive airway disease in the geriatric population? Obstructive airway disease as whole, what are the challenges to treat?
As a group, obstructive airway disease are perhaps the commonest, most prevalent disease among the elderly population, and we combine COPD and asthma. Asthma, of course, occurs in the younger population, but if the patients go on to the elderly age group, then they carry the disease with them. So these are very common diseases. Now there are multiple problems in these patients. Firstly, the diagnostic difficulties. We require lung function testing, and we have just now discussed the practical problem in doing lung function testing and the interpretation. The requirement that these patients must do the test as required, give the acceptability and repeatability criteria, then the proper use of the right reference equations. So our diagnosis has to be correct. So diagnostic modalities like lung function have to be used properly. Then there are management issues. Standard management of obstructive airway disease by use of inhalation therapy. This population, because of their cognitive impairment or arthritis and such problems, may not be able to use a meter dose inhaler or sometimes even a dry powder system. So very often we have to depend on home nebulizers for these patients. So the use of home nebulizers, unfortunately, the drugs that we use in this population, both the LAMAs and the LAMAs, they are now available as respiratory solutions. So home nebulization is a very good and viable alternative for this population. Then issues regarding the choice of medicines. These patients have comorbidities like prostatic enlargement. So in some patients, tiotropium may be contraindicated. So that is one thing that one has to be careful. Fortunately, glycopyrronium is a very acceptable alternative. Then this population has issues of compliance and adherence to therapy because they are functionally dependent on the family. So they require somebody to help them out with taking their doses properly. And if they don't have social and family support, they may be missing out on doses. Comorbidities can complicate. For example, a patient may be having hypertension along with an obstructive airway disease and is receiving beta blockers. And that would increase the severity of the disease. So the challenges in managing obstructive airways disease are plenty, and one needs to understand the patient's disease and tailor the treatment. So it has to be individualized and tailored according to patient's requirements.
Okay. Thank you very much. And patients with Alzheimer's and all patients, they will not be remembering their drug doses. What time it should be taken.
Yes. Yeah, so they require family support for that.
Yes, sir, definitely. Such kind of issues also should be taken into consideration. Thank you very much, sir. My next question is to Dr. Mahesh Dev again. Mahesh Dev,
Yes, sir.
what are the post-op complications in the geriatric population, and brief about this management in the geriatric population? Management of post-op complications.
Yes.
What are the most post-op complications?
So first of all, let's consider regarding the complications. While considering complications, first one is postoperative atelectasis. It's one of the most common complication which is responsible for the postoperative hypoxemia also. So the first one is postoperative atelectasis. Then next will come postoperative bronchitis as well as postoperative pneumonia. And then the postoperative bronchospasm for especially for the reactive airway disease clients and patients. Then it comes under pulmonary embolism and respiratory failure. It can impact to respiratory failure also, and as well as concerned, actually there is more chances of mucus plug obstruction, which may lead to pulmonary collapse, lobar collapse as well. It's the most common complication we are experiencing, especially in ICU as well as immediately post-operative days. And acute lung injury and maybe transfusion associated transfusion associated lung injury also, and may complicated things may go towards like ARDS. These are the most common scenarios we are experiencing in the elderly population as immediate postoperative complications. So as a dictum, we can say actually like where is the surgical site? Depending upon that, we can even make the risk stratification as well as risk assessment. Actually, where the surgical site is very near to diaphragm, there is more chances of the postoperative pulmonary complications will impact. And several risk stratification scores are there, and actually we are usually, especially all of us are usually using these kind of things like ADISCAT scoring system. In that also they are clearly mentioning like age, site of the surgery, duration of the surgery, as well as hemoglobin status and the recent infection episodes and underlying lung condition. And depending upon that, actually we can risk stratify whether it is mild, moderate, or severe, depending upon the scoring status, and we can even predict prior to the surgery what are the possible preoperative complications also. And if we are elaborating more, actually, we can even classify depending upon the severity of this preoperative pulmonary, postoperative pulmonary complication, like grading systems, grade 1, 2, 3, and 4. And while considering the grade 1, there is actually like just the normal thing, and it's just the deviation from the normal postoperative scenario, like postoperative atelectasis. Here, actually, there is no need of any pharmacological or any intervention purpose. Just we need is actually incentive spirometry or deep breathing exercise or early ambulation. So that is coming in the grade 1. And when considering the grade 2, where we requiring actually pharmacological interventions, like in case of postoperative bronchitis or postoperative pneumonia or postoperative bronchospasm, in that scenario comes under grade 2. While considering the grade 3, where what happens actually like this mucus plug, and in that scenario we may need like there's bronchoscopic drainage or clearance of that secretion. That is comes under the intervention, and so which will comes under the grade 3 category. While considering the grade 4, I already mentioned regarding the acute lung injury, TRALI, as well as this ARDS, depending upon the POTF criteria. And this will come under the grade 3 category. So all these scenarios, by this we can stratify this risk also, as well as this grading system also, and we can even prevent those things. Either this kind of risk happens, we have to manage those things, and in order to prevent those things, I already mentioned prior, actually, we have to do early ambulation as well as early mobilization, and also incentive spirometry and deep breathing exercises. And also, in order to prevent this kind of pneumonia things, we can do subglottic suctions frequently, as well as we can use the tapered cough endotracheal tubes. Thank you, sir.
Thank you very much. Thank you. Sir, Murthy Gokula, sir, next question is to you. Regarding this lifestyle and geriatric, how are they related? Just brief regarding with that. Can you enlighten us?
Thank you, Dr. Toke. I have to disclose that after being a doctor for 28 years, I'm really enjoying the practice of medicine after moving to lifestyle medicine. Just want to make that very clear. And the 6 pillars of lifestyle medicine are exercise, nutrition, stress management, sleep, addictions, and social relationships. And each of these in geriatrics, if you look at it, we want to avoid disease, we want to maintain cognitive and physical function, and we want to preserve their engagement. So if you look at the 6 pillars and healthy aging, when you do practice this on a checkbox, like every day you're doing these things, which I'll tell you what to do, you'll have less chronic disease, better physical function, better cognitive function, engagement with life, resilience, and non-frailty, and less sarcopenia. And what do you do to do this? You know, I'll make it very simple. For nutrition, please, I understand I also grew up eating meat every day in India, and it became 3 times a day in USA, but now I'm a complete plant-based, whole food, whole grain nutrition. And again, I told you the pathophysiology of all chronic problems are because of inflammation and insulin resistance. And the things that cause inflammation are processed foods. India is moving towards a lot of processed foods, quick making, 2-minute noodles. They're all a disaster. Refined flours. When you refine things, you chemically process them, and that causes inflammation, like white rice, white noodles, white lasagna, white pizza, white bread, you know. And then the other thing I tell them is animal and dairy products and the oil, because it's saturated fat, that causes a lot of free radicals, and that cause problems. And then sugar is the most inflammatory substance, and you avoid sugar, and refined flours, and then gluten and corn, and they're all kind of genetically modified. They have a problem. So if you eat a lot of brown rice, you can eat millets in India, and eat proteins through lentils. We have one of the most exhaustive collection of lentils in India. And then eat fruits and vegetables. Even now, there was a worldwide study with 300,000 people across the globe, and it's dismal that most people, and especially if you look at Americans, only 1% eat more than 4 to 5. And now in geriatrics, now we are asked, we have that questionnaire that we have to answer. So eating, and Indians are poor. They have done a South Asian study, eating fruits and vegetables. So I make it simple for people. Have a rainbow in your plate. Lots of color because of antioxidants and all that. And as far as exercise is concerned, you at least walking about, you walk about 48 blocks per week according to American standards. which is like 10,000 steps now, they say that. But movement is medicine. When you do exercise, please do resistance training, because it's not your marathon running that will save you, but it's the resistance and build of muscle that saves you and prolongs longevity. For stress management, I ask people to start doing meditation, even at half an hour. That affects the telomeres, and it is published and data driven, and the telomeres prolong your life. And for drugs, there is no scope for alcohol, medication, drugs and smoking. But then, we are all in India, especially Telangana, where I come from. I understand it's more, the money spent on alcohol is more than the GDP of some small European states. That's how much money we spend on alcohol. Alcohol is inflammatory. And body mass index, 18 to 24 is the ideal body mass index that you should have. And sleep is very critical. 10 o'clock is when you should sleep. 10 to 2 is when your body detoxifies. So try to sleep by 10, wake up at 4, 5. But this is just another thing for sleep. Stress management, addictions, social relationships, very, very critical. And in geriatric patients, social isolation is common. And social isolation doesn't mean that you're just sitting at home. What social relationships is you getting up in the morning and saying hello, which I don't think is part of the culture. We're very serious people. We try to, but that's wrong. You should just say hello to everybody you meet, talk to the people you don't know, and try to mingle with people and try to do that. So this is how you can change. I say that because this is all related to sarcopenia, frailty, all the geriatric syndromes. And one of the question is, when you're eating plant-based whole food, whole grain diet in geriatrics, we check B12 on a yearly basis. We check thyroid, T3, T4, TSH, and you'll be amazed to see how many people on the lower limits. We check male hormones, vitamin D, PSA and CPK, and show the level of CPK so low, and patients get really, and then I've seen that people start doing exercises and helping them. So I think in 2 minutes, I've convinced, hopefully, you guys to kind of change your lifestyle. And the data is very clear. I'm 55 and I changed at 53. And I'm not trying to brag here, but when I did my half marathon, which is 13 miles, which is approximately 20 kilometers, I guess, it was 2 hours and 40 minutes. And I started doing resistance training through Zoom from India during COVID. And now I ran a half marathon, which is 13 miles or 20 in 2 hours. So it can be done at my age. And people are planning to retire, but I'm not planning to retire at 58 like in India. I'm planning to live for 90. And even at 90, I want to be running and doing my exercises, eating plant-based diet, doing my yoga, and doing my pranayama. Please try to embrace the Indian values and Indian value systems that have been given from traditions and long, and we have changed to the Western culture, which is a disaster and I close my case for lifestyle medicine in India.
Thank you very much, sir. It's actually a big topic. We have elaborated into 3 minutes in very much convenient way. And again, you are focusing on this Indian yoga and all exercises. Thank you very much, sir. With this, we will conclude our today's question and answer session. Now we'll go to some audience questions. Chhabra sir, should we go for audience questions?
Okay, please 2 or 3 questions because we have already overshot the time.
Yes. First question is from Dr. Rishikumar.
Dr. Krishna has to put up this on the YouTube also, and only then we can go. He has just sent a message.
Yes, sir. What is the reason that the elderly are more prone to tuberculosis?
Firstly, the immunity, there's a reduction in their immune defenses, and that is what makes them more prone to a relapse of the initial infection that occurs in childhood. So by the time a person reaches the elderly age group, he will always have a bacterial infection. The bug will already be there. And studies have shown that Montu's positivity, that becomes negativity as the person ages. So there is a waning of immune defenses plus other disease which would make the person more immunocompromised. These may come in. So these make the person more susceptible to either a relapse or a reinfection. So that is why tuberculosis is, and plus the presentation may be a little atypical, not getting typical fever, only weakness, or they may not be able to reach the health facility on their own. So diagnosis may be delayed. So these are the special problems in tuberculosis in this population.
Okay. Thank you. Dr. Professor C. Mohan Rao, he has asked, is there any role of probiotic to strengthen the lungs? Is there any role of probiotics?
Well, if it's a one-line answer, then there is no proven role for probiotics in lungs. Having said that, probiotics are generally considered to balance out the adverse effects of the harmful bacteria which may be there in the system. But it adds to the cost of therapy, and that would be polypharmacy if these drugs are given along with the essential ones. So no evidence-based role for these.
Yes, sir.
Thank you, sir, for saying that, because I see that you have drugs mixed in India with antibiotics and probiotics. Thank you for clarifying that, Dr. Chhabra. It's very helpful.
Thank you very much. One more question from Anupama, Tamil Nadu, Coimbatore. TT, herpes zoster, hepatitis vaccine for geriatric population. Is there any role? She's asking us. Murthy sir, please.
Yeah, absolutely. As I said, we definitely give herpes zoster for 50 years and above. There is clear data, and people have elucidated that you'll have immunosenescence and especially T cell deficiency. They're more prone for viral infections. So you should give herpes zoster and pneumonia vaccine, as I elucidated. And so you must. I think that's a short answer because of time.
Okay, thank you.
And Tdap, tetanus is very underrepresented in the vaccines. I actually wrote a paper and published when I was a resident. Tetanus every 10 years. We give now Tdap because of the rise of pertussis in US, but should be applicable in India. I'm not so sure about the infectious pattern. But Tdap, flu vaccine every year, pneumonia vaccine, herpes zoster, and we do that, and COVID now.
Okay, sir. Thank you, sir. Next question is from Dr. V from Maharashtra, Pune. Is there any role of free radicals in aging?
I can, yeah. I mean, I'll give you a very simple answer. When you eat meat, okay, the gut, as I said, I check gut bacteria. I check gut microbiome in my clinic. There are labs here which we do check, and we check for oxidation, we check for methylation, we check for free radicals, we check for all these things. And being from India, I like to look for inexpensive ways of dealing with this. If you practice the 6 pillars, I have shown in my clinic that you don't need to measure this gut microbiome and talk about free radicals. If you eat meat, it digests and causes what is called activated glycated end products. And then it causes TMAO also, and that promotes atherogenesis. The AGEs, which are all in foods, actually, in meats, there are 60 times than plants, and then they promote cancer. And so the free radicals that you're talking about are because of the unhealthy high habits that are cumulatively there with aging. So if you practice even now, in 3 months, you'll see the benefit. They've done clear studies. So I'm still asking and requesting all who are attending here to kind of look at lifestyle medicine. There is an Indian Society of Lifestyle Medicine also, and I'm proudly associated with that to promote, because I'm so passionate about this. And free radicals, there are several theories of aging. They try to do all that, but still the acceptable theories, the genetic theory, there are a lot of theories of biology of aging. But more than that, try to practice what's important so that you can beat all the theories of aging.
Thank you. Thank you very much, sir, for this wonderful information. And with this question, I think we should conclude our today's session. And I would like to ask one liner, take a motion from Dr. Chhabra, sir.
Yes, please.
One liner, take home message
On
for
the subject
our
of
audience.
yes, definitely. Geriatric population is a population which requires special consideration. It requires love and care for them to recover, and we must respect their choices. We must help them out because they are dependent on us.
Thank you. Thank you. Dr. Aman, please.
Yes. As geriatric population are at an age that they need a support, a caregiver who is there for them to help them in their day-to-day lives, because geriatric population is not very different than pediatric population. As we give the care and utmost efforts to the pediatric patient, we have to give that much care and efforts to the pediatric patient as well. Geriatric patients as well.
Thank you. Thank you. Thank you. Mahesh Mishra, sir, please. You are muted, sir. You have to unmute. Sir, you have to unmute yourself.
Yeah, I agree with Dr. Aman. We should give attention as much as we give our kids, because experience is also important in our life, in our society. So we should take care of that.
Oh, thank you, sir. Thank you. Dr. Mahesh Dev.
Yes, sir. Sir, Toke sir has clearly said in the introduction session that actually none of our pulmonology texts, actually standard texts, are clearly not depicting this kind of geriatric pulmonology. So that's why I'm insisting these kind of things, actually, like our NH Krishna sir as well as Vijaykumar Shetty sir as well as you selected this topic, and this was really an excellent academic agenda for all of us, and it's really an academic speech for all of us, actually. Like a good sort of discussion came, and we have elaborated a lot of things, and we have learned so many things, actually. And also, they all because of this kind of CCI platform. As an youngster, actually, for me, actually, it's really a good pleasure to sit beside this kind of eminent, renowned scholars and personalities, as well as you, as well as Chhabra sir, Murthy sir, as well as Mahesh sir, and Aman. And thank you, CCI India team, for this opportunity. And it's a very good academic session to us, actually. Thank you. Good night, all.
Thank you very much. Thank you very much. Murthy Gokula, sir, your one-liner, take a Moshesh for our today's wonderful webinar.
My one-liner is following Dr. Chhabra, sir, what he said. All geriatric patients need is love and kindness and patience, and listen to them. And if we can move towards taking back our parents back into our homes and not create senior citizens' homes in India, that would be a great movement. I don't know, but if anybody takes the parents out, they have done intergenerational studies and the health outcomes, and what India had the best. And even now, Indians are prospering because of family life. And it's unfortunate we are seeing that degenerate right in India. And I hope that we can bring back all the geriatric patients back to our homes and give them the vital life that they deserve and improve their function, quality of life through lifestyle medicine. Thank you.
Thank you very much. Thank you. And I would say one-liner that old is gold, and we all should take the care of our gold. So with these remarks and with wonderful discussion, I would like to conclude this session. I would like to thank our CCI family, especially Dr. Krishna sir and all CCI officials, as well as today's our panelists, Dr. Murthy Gokula sir from US, Dr. Mahesh Mishra sir, Dr. Aman, Dr. SK Chhabra sir, and Dr. Mahesh Dev. And thank you all, and good night. We should conclude.
Thank you. Thank you, sir.
Good night.
Thank you. Good night.
Good night.
Have a wonderful day. Thank you.
Thank you.